Hello?
Can you hear us? Oh, we can hear you.
Yes.
Okay. Yep. We're just waiting for the
This
recording
meeting
to
is
start.
being recorded and/or transcribed.
I'm going to now call the May 14th, 2021 Fishers Board of Health meeting to order. For the record, do we have at least one board? We do have at least one board member participating virtually. Can all those participating virtually identify themselves for the record, please?
This is Dr. Vishal Parikh.
Okay, next is our consent agenda. The consent agenda consists of our March 12 meeting minutes. Do I have a motion to approve the consent agenda?
Motion to approve.
Motion by Mr. Hultgren. Second. All those in favor signify by saying aye.
Aye.
Aye. Any opposed? Motion passes. Okay, on to the regular agenda. I'm now going to turn it over to our Public Health Director, Monica Haltz, for her update to the board.
Hello, everybody. I wanted to introduce, we're going to have a couple of other folks talking today. I wanted to introduce Joshua Robinson, our epidemiologist, whom you have met previously, as well as Todd Succi, our environmental health services coordinator. So he's going to talk a little bit about mosquitoes. So these are the things we're going to go over. Since we last met, we did release our annual report. So hopefully you got a copy of that about a month ago. We'll do a COVID update as we have been doing, talk about mosquito control, some other updates for the department, and then also Chris Greisel, our city attorney, is going to talk a little bit about Senate Bill 5, which was recently enacted. So as far as the annual report review, this should look familiar, but we did release this last month as we are required to do under as a local health department. We are required to produce an annual report. The requirements in the code specify that we have to produce information about the budget in that report. There are no other requirements, but of course we had lots to brag about. So we wanted to share a lot more than that with our community and with you all about all of the different services that we've performed in the past year. This is a small highlight of some of those services. Again, these numbers have been greatly exceeded since the data on this slide, because the data on this slide was just for last year. So we are well over 50,000 tests right now to Fishers residents, COVID tests, and I'm sure our videos have had more views and all of that. So I'm going to have Josh come up and talk about where we're at with COVID right now.
Thanks, Monica. So I'll try not to bore everybody too much, but there is a lot to talk about and quite a bit to be excited about. On this slide, in the upper left-hand corner, is a screenshot of our vaccine dashboard. We receive vaccine data on residents vaccinated from the state each Friday. Luckily, we got it earlier today than anticipated, so I was able to update our numbers. When you look at the two blue cards in the top right of that screenshot, 62.44% and 52.5%. That 62 number is the percentage of the eligible population that has received at least one dose, and the 52.5 is the percentage of the eligible population that has been fully vaccinated as of yesterday. This number includes in the denominator the recently eligible age group 12 to 15. 0% of those are fully vaccinated. There are a few that are partially vaccinated. If we look at these numbers, when we take into account the 16 and older age group, we actually have 68% of 16 and older residents that receive one dose and 57% of 16 and older that have received full vaccination status, either one dose J&J or 2 doses of Moderna and Pfizer. We set a target to get 85% vaccination coverage across all of our age groups. We had our first age group hit that 2 weeks ago. Another age group hit it last week, and we are continuing to see large gains across all of our age groups. That's the bar graph down at the bottom. So the reason that I think that this is something to be excited about, the level of vaccine coverage that we have, is that We continually see week over week, our residents in their age group peers compared to the state as a whole are outpacing them in some age groups quite significantly. So the table at the bottom, you can see, for example, the 40 to 49 age group, we have 62.6% of our 40 to 49 residents fully vaccinated. In the states, that same number is 33.88%. The two maps that you see, the green map is first dose coverage by county, blue map is full dose coverage by county, and this includes the 12 to 15-year-old age group that recently became eligible. When we compare across this, our locality leads all other jurisdictions for first dose. We lead all other jurisdictions except one for second dose at 52.5%, and this is Ohio County with a population of 5,000. They're at 57%, but to much chagrin, we just can't outpace that 5,000 group. One thing that I think is quite commendable about our residents and seeing continual growth in vaccination rates, it shows that there is not a large amount of vaccine hesitancy. We're seeing a lot of people go to the vaccine sites. Some people appear at the vaccine clinics. And in terms of jurisdictional comparisons, as of Tuesday of this week, 1% of all U.S. counties had a population coverage of 50% fully vaccinated. We've had 50% fully vaccinated for greater than a week. Moving a bit on to cases and case rates, the upper graph you see is age-specific case rates per 1,000 population. The data ending on the 7-day period of May 5th. The highest case rates per 1,000 are in the groups with the lowest vaccination coverage. The graph down at the bottom shows you 60 to 69-year-olds in their 4-week average age-specific case rates. So we're starting to see across age groups as vaccine coverage increases, case rates are going down, but the highest case rates remain among those with the lowest vaccination coverage. So in terms of this, we're redoubling our efforts, moving just from our vaccine site to mobile clinics out in the community. We had our first neighborhood association pop-up clinic yesterday, and I was there right next to a very nice jogging and footpath, and a lot of people were running by and giving thanks for the efforts, and it was very inspiring to see the people that stopped in serendipitously as they drove by to receive a vaccine, and we're very thankful that we were in their neighborhood to be there. So we are moving to have more of these pop-up clinics at businesses, organizations, and take the vaccine out into the community because we want to see these numbers here continue to go down. So our percent positivity, you'll see on this picture here of our dashboard, that is the Hamilton County percent positivity. It's at 9.3%. That's been going down over the last couple weeks. It actually, as of 12 p.m. today, is at 8.5%. Our case incidence rate peaked almost at 20 a couple weeks ago, and it has been going down slowly, but going down now. It's in the mid-teens. We're seeing on average a number of cases around 80 to 120 every 7-day period. But overall, things are starting to trend down a bit. So we do want to make sure that we adequately advise that with still 80 to 120 cases, there's still a high level of risk for transmission within the community. We're not at a non-zero number here, and the risk still remains high. So we've been in our level 3 category for over 2 months now. That's the orange category. We look for stability in some of our key indicators before we advise moving down a risk level category and change the guidance we communicate to the community. Based on the numbers and the trend right now, it's unlikely we'll move from our level 3 orange to level 2 yellow, at least until early June. We also get data and information from the state on sequencing of cases to identify variants. The sequencing amount is still quite low, so any data that we get or any other jurisdiction they get isn't a true representation of the number of variants out in the community. But we know as of through May 12th, they have identified 12 variants in Fishers. The majority is the one colloquially known as the UK variants. There's also the Brazil variant and the California variants. In this table, which I won't read through all the text, I added some characteristics about how does this impact transmission by variant, what's its impact on vaccine efficacy. So far, the variants that they have enough data to look at, the data is pointing toward the vaccines remain efficacious and effective, primarily at the severity of disease and death rates, but also in preventing infection as well. I also put a note on here about our breakthrough cases. We've had 18 breakthrough cases identified as of early May. Those are individuals that have contracted COVID and have a positive PCR test 14 days after their last vaccination dose, so when they're fully vaccinated. Would you like me to pass it back to you, Monica, for the news? I'll be sitting over here if you want to be bored any further with more questions.
Okay, so as far as recent activities that we have going on, as Josh mentioned yesterday, and you probably heard on the news, 12 through 15-year-olds became eligible starting yesterday for receiving the Pfizer vaccine specifically. So we saw a definite spike at our vaccine site at 3 p.m. as soon as school let out yesterday. It was very fun. So we're definitely looking forward to getting that group vaccinated, especially because, the younger ages right now who haven't yet been vaccinated are where we're seeing most of the COVID spread currently. So the more we can get more people rolled down and into the vaccination status, then the faster we're going to decrease the ongoing spread that's still happening. The other thing that happened yesterday was that the CDC put out mask guidance. That is an update. So they had previously said fully vaccinated individuals were free to do pretty much anything outside except for go to a large crowded event without their mask on. And then they had very specific, sometimes indoors, sometimes not. But yesterday they changed that guidance to say that fully vaccinated individuals can do almost anything without a mask, with the exception of being around an immunocompromised person, or if you're sick and being evaluated for COVID, you're still supposed to wear a mask even if you're fully vaccinated. I think it is possibly worth a discussion if you guys want to discuss this a little bit, just as far as how this is best communicated to our community. I think this is really great news from the CDC because it very clearly underscores the importance of vaccination and being vaccinated, as well as the effectiveness of the vaccine, which is fantastic. We know that it's effective. All of our local data and graphs and charts that Josh has presented to show the same thing, that as the vaccination rates go up, the case rates go down. It underscores all of that. I think what we just have to make sure that we keep in mind is that there are still pockets of people out there that can't get vaccinated. We have a young community with young families, and young kids are not yet eligible for vaccines, so we have to kind of make sure that we know that there are situations where there are going to be people that are more comfortable in those situations and other people that are less comfortable in those situations. And as far as businesses go, it's going to be the same kind of thing. There are different businesses serving different types of clients. So a preschool is going to want to probably take a different tack than someone who is an office-based employer who doesn't have any customer service component and is going to want to take something different than someone that's heavy in customer service, like grocery store, something like that. So I think that's going to continue to be a challenge for our businesses as they try to wade through the next steps on that. As far as the pop-ups, I know that Josh mentioned that. We are excited about going forward with those. We do have the form on our website where community organizations, neighborhood groups, businesses can submit, and we will contact them about having a pop-up clinic at their site. The goal is really to try to target populations that we don't have as great of an uptake in our vaccines, and part of that's due to time. Just they haven't been eligible very long. So we do want to make sure to get to those places where we're able to target those groups, or any groups that are just, too busy, haven't made it to the appointment yet, or haven't figured out how to navigate the state system yet, or whatever the barrier is that's preventing people from coming in. We want to make it as easy as possible. So we are at the farmers market every single week. We started last week, and we did vaccinate people there. We'll be there again tomorrow morning. And those are for walk-in appointments. We also are having walk-ins at our vaccine site all the time, and people can request Pfizer or J&J, so vaccine of choice pretty much, and we're having great success with that. We're seeing probably 50 or 60 walk-ins every day, so that all is going well. Mentioned Senate Enrolled Act 5. Like I said before, Chris is going to talk about that here in a little bit and explain what that means for us as a health department. Because it does change things a little bit for us and what our capacity is and capability is from a health department to be able to make orders. And then just some non-COVID things. We haven't been sitting idly by, not doing anything other than COVID. So we are preparing to start help people get caught up on regular childhood vaccines. I anticipate that this is a great need this year more than most years, as people have missed a lot of provider appointments. So the summertime is a great time to focus on that and get people caught up on other vaccines. The other major news, along with the 12 to 15-year-olds being eligible for the Pfizer vaccine that came out from the Committee on Immunization Practices Wednesday, was that we can co-administer vaccines with a COVID vaccine. So we're not quite ready to do that yet. It's going to take a little tricky sorting out between medical record systems, but it does remove an additional barrier. So there was a 2-week kind of lockout period between administering one vaccine and the COVID vaccine for anybody. They removed that and said they recommend that you administer whenever you have the person there, and that you not delay it because of another vaccine. So you can administer them with other vaccines or within the 2-week period now. So that will facilitate getting some more shots in arms. The State Department of Health is also getting these vaccines out to more of the private providers so they can do that in their pediatric offices and other places as well. We have been working with our paramedicine team, community paramedicine team in the fire department to kind of streamline some of the mental health initiatives, work towards a more formalized, almost a case management process with some of those incidences, as well as some other incidences where we can, kind of help and facilitate and look towards what are some broader outcomes that we can achieve as a health department in some other areas with some partners that are handy and nearby and have already been doing a lot of this work. So we're excited about that. We are also starting to have some health education offerings in the community. We'll be putting out a few of those through our Parks Bulletin that people can sign up for in the community. So we're starting to do that. Hopefully next year will be a little bit easier to go into the schools and do those kinds of things as well. But our health educator has been very busy trying to set up those partnerships as well. I know that Todd's group is really busy with pools, or will be starting in 2 weeks, or a week and a half, or whenever after Memorial Day. Whenever all the pools open, we have all the permits done. We'll just have to start inspecting them once they open. So, that's just another thing coming up along with vector control. With the warm weather comes bugs. So we'll be talking about that here in a second too. And I'll have Todd come up.
Monica, a quick question.
Yeah.
And then just curiosity, are you seeing people take preference Pfizer or J&J, or what are people choosing right now, actually?
So most people seem to be choosing Pfizer. The Moderna just has an extra week to wait. There are a few people that seem to prefer Moderna for some reason, but we are at this point supposed to be using Pfizer for first doses, so we're able to give people second dose of Moderna, but the primary amount of our supply is focused on Pfizer, but we really don't have that many people requesting Moderna. I think we would have seen a much greater uptake with J&J, but the pause on the vaccine definitely significantly hurt the demand for that particular vaccine. We do still get people coming in on walk-ins, and that's primarily what we're using for these pop-up clinics is J&J, because we don't want to have to come back. But we are bringing Pfizer as well to the farmers market and to the pop-ups, because we want to still be able to offer it to people under the age of 18, or for people that really don't want the Johnson & Johnson. But for most people that have had a harder time getting into the vaccine site, they seem pretty happy with having the Johnson & Johnson at the pop-ups and those other offerings. And then, like I said, we do still get a few walk-ins for that.
Great, thank you.
Yeah.
Yeah, quick question. Do you think there's value with the HOAs and some of the property management companies that manage, like the Mark and Fishers, where there's a lot of 20-somethings as far as vaccination opportunities?
Yeah, we're starting that outreach to talk to all of those agencies, particularly apartment complexes, particularly places where there are younger people. As Josh showed you the data, the younger age groups are still a bit behind, which they have had less time to get fully vaccinated, so that's not surprising. They also tend to be having maybe more challenging schedules to work with. Many people working in the service industry are having a hard time getting to appointments, so we just want to try to make sure that we're facilitating all those opportunities for people wherever they are. Yeah, but apartment complex is a great idea. That's what we're working on. I know you guys really want to talk about mosquitoes.
I think the board all received the packet of the proposed granulate that we were going to use to treat. We're going to focus mainly on larviciding for now. The couple topics we wanted to discuss was proposed policy, times and places, or times and areas. We were trying to determine whether or not we were going to be more proactive, reactive as far as our approach. I guess we kind of already took a step forward with that. We're proactively scouting anyway. Been working a little bit with Indiana State Department of Health, and I learned how to find larvicide, so I can now stop by your houses, check your backyards, that sort of thing. But so we've identified larvicide. We've also got to the point where we figured we're going to trap as well. The trap you see in the picture, the one on the right-hand side, is a gravid trap. That's the trapping process that we're going to utilize. It's the easiest. It's easiest to set up, easiest to use, and we can hide it. That thing hanging from the tree is probably going to get stolen, from what I've been told. But we are going to focus with just the granulate for now. We are going to contemplate an oil. The oil is made by the same company. The MSD sheet is just about the same. I can print it off and send it to the group. But did anybody have any questions about the initial product? No? Okay. We are going to create a section and viewpoint for the complaints to come in. Essentially, the complaints will funnel through, probably going to funnel through me, get filtered out to whether or not it's an area we're going to treat, be sent on to Public Works, and then dispatched from there. We're hoping to do it in a 24 to 48 hour turnaround. We get the call within 48 hours. We have it tested, sampled, and then treated if need be. Budget components, I think we've kept it pretty modest so far. I think we're probably at about the $2,500 mark to get started. We're intending to use 3 traps. I believe we have 8 staff members that are certified to disperse the granulates. We've already had the equipment. We had to retrofit some of that. It's basically the traditional steel backpack leaf blower. It gets retrofit with a hopper that will essentially just shoot it straight out. So we have those guys ready to go. Staff utilized, like I said, there's 8 of them. As far as the rest of the staff utilized for this, it's probably going to be myself and 1 other. We did make some adjustments to the traps. The initial traps we looked at ran on D batteries. So essentially they would only run about 12 hours, meaning it had to get set after hours and picked up in the early hours of the morning. So that would have had us asking Public Works to send a guy over to go out and set these for us so we can collect them in the next morning. We upgraded the batteries to 6-volt rechargeables that'll run for 26 to 28 hours, so we can actually set them during a normal workday and still pick them back up the next workday. So I think we were able to eliminate the additional need for staff from Public Works. So essentially, it'd be about 3, anywhere between 2 and 5 guys, depending on how crazy the mosquito stuff gets. But on a day-to-day, we'll probably just have 2 people until it comes time to start applying the Vectomax. Sure.
So just to jump in a little bit, the product that we're using is a granular product, so it goes into standing water and then goes to the bottom of the water and kills the larvae that are in the water. So it's meant to be applied to areas of standing water only. We are not proposing to do any kind of fogging or spraying at this point in time. I think people would be just as many people who might be asking for that. There would be the same number of people who would be complaining about it. And at this point in the process, it doesn't make any sense to take that approach when there are available larvicides. The oil, I think, targets a different stage of the development of the larva, so that would be the possible use of using that product in addition to the granular product. On some occasions, this is kind of this product it sounds like it's fairly universally utilized by most health departments for this purpose. We're still proposing that we would only do this on public property, not on private land, with the possible exceptions of if there's an abandoned swimming pool or something like that where somebody hasn't been taking care of it, and we just would take care of it in those cases if we couldn't. There was nobody there to take care of it themselves, right? And in right-of-ways, okay, standing water and right-of-ways, yeah.
Todd, I know you said the MSDS sheet we can get a copy of, but is there anything remarkable from a safety perspective with the larvicide?
It's pretty much edible. Farm animals eat it. It's organic certified. I mean, it's one of the safest products available to use. I mean, it's pretty safe. It's water soluble, soap and warm water. Some of the videos that I've seen of other departments using it, they weren't even wearing gloves. Obviously, that's not going to be our approach, but just as an example of the safety of the product.
The recommendations are to use a respirator when you are applying it. So we are recommending that Public Works continue with that process, just because they're going to be spewing it out from a propelled instrument. But for the water and the water table and the safety of that, everything looks really, really good. And I know you guys had a look at it as well. Any questions? Does that sound like a good process for mosquitoes? Mostly complaint driven, although we will be doing some of this trapping and monitoring. So if there is a case like we talked about for public health need, if we are, if or when the West Nile pops up anywhere in the county, we get a notice, and then we will start more aggressively trapping and treating any kind of areas where we see those concerns.
So with the traps that we purchased, we are going to be working with Indiana State Department of Health for testing. So we will collect them, we will essentially freeze them, and then there's a process for getting them to the laboratories. So they will turn around our mosquito samples every 5 to 10 days. So we'll definitely get an early indicator of whether or not we have disease breeding or disease carrying mosquitoes.
So Josh has put together these other numbers. We have some of this data in our annual report as well for last year. So it's not just COVID that we track, although that certainly is the majority of what we've been doing lately. You can see how far outpaced the COVID numbers are from the other communicable diseases. If we have less than 5 cases of any particular disease, then we suppress the counts, but you can see the different diseases that have been reported to us so far this year. So we are very busy with those other things as well, just as all health departments are. Again, there are 72 other reportable conditions besides COVID. And then this is just a look at some of the other items, particularly that our environmental health team focuses on, although we do have our birth and death certificate request through this process as well. And we were having our event approval process through this system as well. So you can see that we have been doing a lot of record requests and permitting. Our restaurants were all renewed for permitting starting January 1. The pools were all due April 1, so we've made a lot of progress on that. They will show as completed after they've been inspected. So we see that we typically have a lot of active ones because they haven't yet been through the whole process. It doesn't mean they don't have a permit, but they're somewhere in the process and we haven't yet inspected them. So that's kind of how that works. Any questions about that? No. So as we move forward for the next quarter, obviously we're going to continue with our COVID efforts. That still is going on. Hopefully that will go down as we vaccinate more and our case rates go down. We have set that lofty goal of 85% for our community. So we're really working towards doing everything we can to hit that goal. But we do depend on the rest of the community to help. I mentioned before the immunization catch-ups for people who may have fallen behind in the past year. Working on our mental health initiative and seeing what else we can add to that. So if you have any great ideas, I would be happy to take those. Vector control, as we mentioned, Todd's group is taking over mosquitoes. There are other vectors out there. I think tick-borne diseases have seen an increase in recent years, so we're going to start putting out some messaging about that as well, and anything else that pops up. Continue to educate staff, pursue grants and opportunities. We're seeing various different grants coming in from the State Department of Health, just to every health department. Most of them are COVID focused, but we do have some regular ones that are coming in as well. And then, as we mentioned in our annual report, this idea of Public Health 3.0, which is kind of integrating health into all things, almost a health for all policy, where we try to figure out how we can have health considerations in everything that we do. So we are in discussions with economic development, planning and zoning, the Parks Department, just to try to figure out how we can make sure that everyone has health considerations in mind as we're planning different activities and development, so that we can avoid any unintended consequences for people's health by focusing too much on one area or another. And then we'll be participating in the hospital's community health assessments coming up, and looking towards finishing our own as well, or starting our own. Chris will come and give an update about Senate Bill 5.
Perfect segue from talking about larvicide.
Yes.
So there's been a lot of talk about Senate Bill 5, and you've probably seen it in the news. General Assembly, in essence, passed Senate Bill 5, was vetoed by the governor. General Assembly got back together this week, overrid the veto, so Senate Bill 5 is now law over the governor's veto. From a 30,000-foot view, going forward, or let me back up. During this pandemic, as a local health department, as a local municipality with a health department, we've been able to kind of chart our own destiny in accordance with the governor's executive orders. So up until this law passing, we've been able to be more restrictive than the executive orders that have been issued by the governor. So the governor, at the very onset of the pandemic, issued the statewide emergency. He started issuing executive orders. We followed a lot of that guidance, but we were also more restrictive in some of that guidance, as were many communities across the state of Indiana, to deal with this in their own local way. Senate Bill 5 now comes in and says, if you're going to do that in moments of state emergencies or local public health emergencies, you're going to issue a health order that is more restrictive than the governor's state order, or provides additional items that weren't included in the governor's executive order. That order has to be approved by the city's legislative body, or city council. So as a health department, we no longer have that unilateral authority to be more restrictive than what is found in the governor's executive order, or to add more information during times of emergency outside of that executive order. Yeah, so, right, no, so that's a good question. This is just specifically tied to the health laws. So we're not talking about other disaster emergencies. So under, the governor has the ability to issue an emergency disaster under a specific Indiana statute. It's 1014-312, and that gives him a list of opportunities to issue emergency disasters in that realm. As a local health department, we also have the ability to issue certain emergency orders, which is specifically tied in this instance to COVID. I mean, the conversation right now, it's for this purpose in this conversation, yes, it's specific to health orders. So it doesn't involve any of your stuff with maybe fire, EMA, or emergency management, any of that nature. But with respect to health orders that would come out of this health department, of this health board, it certainly does. And so what we would do going forward, if this ever occurred, is if we wanted, and you might have saw that the Indianapolis City County Council, in fact, just got together this week to approve their public health order, which is more restrictive than the governor's current health order for the state of Indiana. The City County Council approved it. It's now in effect for Indianapolis. So here going forward, if we wanted to be more restrictive than the governor's executive order, we would more than likely bring a recommendation to this board for your guidance and approval, but it would have to be adopted by our city council as the legislative body for the city. In addition to that, any enforcement action that we would try to take based on those orders are directly appealable to our city council. And there's a process and a procedure that's been put in place through the state statute that allows any person or entity to appeal those enforcement actions directly to our city council. So if in those times of emergency, we issue an order, somebody wants to challenge that order, that enforcement action that's been placed on themselves, they can bring that appeal directly to our city council. and then there's a mechanism to bring that appeal to Superior Court as well, once we go through the administrative process. So it does not. Initially, the language was written that it does. The legislative body has permissive ability to decide whether they're going to stay the enforcement action during that appeal window or not. So that's a decision of the city council. So part of this work on the back end is that I'm going to have to work with our city council to develop a process and a procedure for if and when these scenarios occur, both in the review of health orders that may come out of the health department and a review and appeal process for enforcement actions that may be brought before the city council. Under the statute, the city council can choose to deny the appeals too, which would probably expedite an appellant argument in city court. So the purpose, I think, of the General Assembly was they were frustrated that elected officials weren't more directly tied to some of the decisions that were going on in the state of Indiana, and that's debatable, right? We know the appointment authorities of the board, of the health officer, of our public health director, but they saw the direct accountability being directly linked to legislative bodies across the state of Indiana. So for all health departments, whether you're in a county, those are now appealable to the legislative body of the county, the city, vice versa to our city council as well. So they're adding that element so that elected officials can have direct accountability when issuing these orders going forward. So I'm happy to answer any questions that you may have. We're going to be working through the process of trying to develop this criteria. Hopefully things continue to trend in the right direction and we don't have to run into these scenarios. But if and when we do, we'll at least be prepared to discuss it and talk about it and have a process moving forward. No, it'll go to the Hamilton County courts. So there's an appeal process where if an enforcement action is taken, the council hears it, makes a decision, that exhausts the administrative process, and then the person can then go take it to the county court. So there was a lot of, as you know, this session was filled with a lot of conversations about local health departments, the role of the health officer, managing these crises. And Senate Bill 5, was high on the priority of the General Assembly, right? So we're now going to react to it just like every other local health board is in the state of Indiana, and we'll make sure that we have the plan in place.
My concern, and a lot of the public health community's concern when we first started looking into this was that it would also restrict our ability to respond to other things that are more commonplace, such as a hepatitis A outbreak from a restaurant or any other kind of communicable disease issue or public concern. My understanding of this is that it should not. This only applies in situations where there is a declared emergency, as Chris said, whether that be under the governor's executive powers or we can also declare a local health emergency. But those are the only situations in which it would apply. So if we don't declare an emergency, if we have a localized issue and it's not at the level where we have to declare it as an emergency, and it's not a state level issue, then it wouldn't apply, which is somewhat reassuring.
Yeah, I think to Monica's point, oftentimes at the General Assembly, you get the law of unintended consequences. There's an issue that they're trying to attack, but the solution that they present may be a little bit more broad than they originally thought. And I think here there's a specific intent to control the nature in which these public health orders arise during times of COVID, right? And nobody imagined an issue like COVID with respect to our emergency management laws that we have in place that were largely created right after 9/11. I would tell you that I think there was enough flexibility within those laws that allowed us to manage the crisis, but the General Assembly wanted to put this additional protection in place for themselves and for the elected officials so that there was a review process beyond the health department. So we'll be able to move forward and create that process again. And we'll be sure to bring back those procedures and review processes to you so that you're fully aware of how we're going to move going forward.
Yeah, and I would also say that the danger of adding these additional steps, you know, as you know, we had come to you guys initially when we were implementing the mask mandate back in July of last year for your recommendation and approval, and then we did go to City Council and let them know about it as well. We didn't have to get their permission at that point, so this would have added another layer, more complexity. So in situations where we need to move quickly, then it could become really problematic, and will take a lot more on the ground, fast work to try to make sure everybody's on board with that situation. So that is just a general concern for hypothetical situations going forward.
So does the city council have to vote on these resolutions during like a general session, or to that ground, obviously step one, it has to be an emergency, so that would tend to mean that we need to move quickly. So if this body makes a determination on a Friday, can the city council make an emergency session, or can they vote on that over the weekend, or does it have to wait until a general city council session?
Yeah, so we have emergency rules that can bring a council into session rather quickly. And like I've had these initial conversations with Monica, in times of emergent need, we would be bringing our council into the fold a whole lot sooner, right? Beforehand, there was a general need for our city council to be aware of what was going on. We certainly made them aware of the decisions that were forthcoming from the health department. Now there's more of a collaboration and an ultimate decision by the council on these issues. So they are the direct forefront in making some of these hard decisions. So if Monica has the understanding and the ability to say, hey, I really think we're going to have to implement this for the betterment of our community, well, that conversation now gets directly tied to our council and having them understand the parameters of what that issue is so that they ultimately can make that decision.
Any questions? Any questions virtually? No. It's fantastic progress, but we're not at herd immunity yet, I think is the larger point. Do you happen to know what the percent vaccination is for the full community? Not eligible population, but the full population? %, so it's a bit lower, right? Because we have a whole bunch of kids that aren't yet eligible, right? However, the 60 through 79-year-olds are 90% vaccinated, so they, without knowing the true herd immunity number of what's required, as long as they're only with 60 to 79-year-olds, they should be pretty okay. No, it's fantastic work on the part of our residents to have taken up the vaccine so vigorously. And we're going to do everything we can to continue to facilitate that. It's good for everybody. It's good for our kids trying to get back to normal. It's good for our businesses trying to get back to normal. The more of us who are vaccinated, it's only going to help everything. So.
Nope.
Second. Aye.